So now I'd like to introduce our next amazing presenter, Dr. Jay Nayak, and he's the co-founder of the Men's Health Clinic here in Winnipeg and an associate professor of surgery at the University of Manitoba. He is the former research director and current program director for the section of urology residence program. Dr. Nayak received his medical degree from the University of Manitoba, and after completing his urological and surgical residency at the University of Manitoba, he completed a fellowship in urologic oncology in Seattle, Washington. Dr. Nayak is a member of various national committees, including being an honored member of Bladder Cancer Canada's Medical Advisory Board. Dr. Nayak is an expert in male urological cancers and men's health issues, and is a fellow of the Royal College of Surgeons of Canada, a fellow of the American College of Surgeons, and board certified by the American Board of Urology. Dr. Nayak, thank you so much for attending today, and I'll pass it on to you.
Thank you. Good evening, everybody. So I see some familiar faces back there. Hey, guys. Do I need the mic?
Yes.
Use the mic. Okay. So again, good evening. Thank you to everybody and to Bladder Cancer Canada for having me here today. I gave a similar talk pre-COVID. I remember some of the feedback from patients at the time was that it was actually pretty helpful, just to kind of understand the lay of the land, sometimes why we do what we do, the different surgeries. I know Dr. Ahmad spoke about the non-muscle invasive bladder cancer, so I'm kind of focusing on the surgery of bladder cancer, and when it comes to surgery, part of that is non-muscle invasive disease, which is where a lot of the intravesical therapies come up, but then the other big one is radical cystectomy. So we'll talk a little bit about what that means and what that looks like, really. Let's see if this works. Okay, so I'll talk a little bit about some statistics, the anatomy to be aware of, types of bladder cancer, staging of bladder cancer, and then the surgical treatments. What I won't be talking about tonight will be things like radiation or chemotherapy. That's a little bit beyond the scope of today's talk. But if you do have questions, I'm happy to try to answer those questions. So bladder cancer 101, you probably, I didn't catch the beginning of Dr. Ahmad's presentation, so this might be a little redundant, but bladder cancer is very common. And I was saying earlier that Bladder Cancer Canada in particular is one of the most engaged patient support, patient advocacy groups. Not only because it's common, but well, because it's common, but it was also generally an underserviced area, I would say. Like classic things like prostate cancer, breast cancer, those get a lot of face time and a lot of awareness campaigns about, but bladder cancer was almost forgotten about until organizations like Bladder Cancer Canada came up. And it's a good thing because it's such a common cancer. In terms of what causes it, there's a couple of known risk factors, like smoking is definitely the #1 risk factor. So that applies to people who've smoked before, and if you have bladder cancer, I strongly urge you to stop smoking because it also might increase your risk of recurrences. It also impairs your ability to heal properly after some of the surgeries we're going to talk about. Radiation exposure. So sometimes when we say radiation exposure, that doesn't necessarily mean that you lived next to a nuclear reactor or something like that, but sometimes we use radiation for other types of cancers. For example, prostate cancer. Radiation is commonly used. And so one of the things we often counsel patients with prostate cancer about is, you're dealing with a cancer right here and now, but there's inherently a risk that 10, 15, 20 years from now, you might get another cancer, like bladder cancer, because of that radiation exposure. So radiation, when used appropriately, can be very good, but in general, it can also put you at risk of other problems such as cancer, chemical exposures, arsenic, dyes, rubbers, textiles, the dry cleaning industry, for example, family history. So if you have a family history or a family member who was affected by bladder cancer, in theory, it could increase your risk. Now, a lot of bladder cancer is spontaneous. It's not related to hereditary predisposition necessarily, but there are some genetic syndromes like Lynch syndrome, for example, that can put you at risk of colorectal cancers and urothelial cancers as well. So family history is something to be aware of. And then there are certain other past treatments that one may have received. It's not as common to see this sort of connection, but some medications like cyclophosphamide or whatnot, sometimes that can increase the risk of developing a bladder cancer later on. In terms of the symptoms, by now you probably know blood in the urine is one of the most common symptoms to see. Sometimes that's blood you see with your own eyes, which we call gross hematuria. Sometimes it's just picked up on a urine test, that's microscopic. Both warrant investigation. Painful urination, abdominal pain, back pain, and especially for the females in the room. And I say this because females often or more often get urinary tract infections. And with the UTI, sometimes there can be some microscopic blood. So it's very common for women to be delayed, have a delayed diagnosis because the blood in the urine is attributed to a UTI. But after the infection is cleared, it hasn't cleared the blood, and yet it's felt to be minimized. Whereas really, blood in the urine should be worked up in all people, men and women. So this is one of the main symptoms of bladder cancer. In terms of how it's diagnosed, well, the urine analysis is what tells us whether there's blood or not. We sometimes do urine cytology, so that's a urine test we collect where we're looking for cancer cells. We do imaging, CT scans, ultrasounds, MRIs, depending on the context and depending on what we're specifically looking for. Cystoscopy. If you know bladder cancer, you know cystoscopy. And everyone knows, like no one looks forward to it, but it's a necessary evil because it's what allows us to check the bladder, try to determine if there's any recurrent tumors, ideally when they're small and easy to deal with, and before it gets too advanced. So in terms of the anatomy, again, this is probably just a refresher, but for the purpose of this, yeah. Okay, so we just have a female and a male body here, but what this is really trying to demonstrate, and the reason I included it, is that even though we're here today talking about bladder cancer, it's important to remember that the kidneys are where the urine is actually formed. So most people have two kidneys. The kidneys filter the body's blood, drains it through a tube called the ureter, which is the yellow, really faint yellow line right there. And that's what brings the urine down to the bladder. In patients who have bladder cancer, irrespective of the type, if it's muscle invasive or non-muscle invasive, there is inherently a risk that there could be disease later on in the upper urinary system, in the urine part of the kidney or the ureter. So that's why, and we'll talk about this later, when somebody has bladder cancer, not only do we do cystoscopy, but we also are doing periodic imaging of the upper urinary tracts. So on that note, what we define as the upper urinary tracts is basically everything from like above the bladder, the ureters, the renal pelvis, the kidneys, and then the lower urinary tract would be your bladder, urethra, and in men they have a prostate about here as well. And part of that, and just hopefully you can see the yellow lighting or the yellow highlighted area, which is in the shake there in a second. There we go. That is showing you that the same cell type that lines the bladder lines all of that portion of the urinary system. Those are called transitional cells. So if somebody has a tumor in the bladder, there's about a roughly 4% risk they can develop a tumor higher up in the urinary system. Conversely, some people start with a tumor in the upper urinary system. And if they start with that, there is about a 20% risk they may develop tumors in the lower urinary system. So for example, if somebody had a kidney removed for an upper tract urothelial tumor, we still perform cystoscopy on them, generally semi-annually, because there is a risk they'll get a similar tumor in the bladder eventually. Now to zoom in on the bladder. So some of this would have been covered with the non-muscle invasive lecture, I'm sure. But the bladder has essentially 4 layers to it, and these layers are all very important. The innermost layer is called the urothelium. That's kind of like the inner part of your cheek, just like the superficial mucosa layer. Beneath this is a connective tissue layer called the lamina propria. Deep to that would be the muscle, and then deep to that still would be the fat, or the fatty layer. And these layers are important because this is how we stage cancers and tumors. We'll talk about a little bit about TURBTs and transurethral resections, but in general, when we are diagnosing someone with any cancer, but let's say bladder cancer, we have to essentially identify a T stage, an N stage, and an M stage. All 3 of those come together to give us the stage of cancer. Like you might hear some people say stage 4 cancer, stage 2 cancer. Well, that has to incorporate all of these things together. But for the purpose of today's talk, I'll be talking a little bit more about tumor stage because this applies to the layers of the bladder. So in the non-muscle invasive discussions you were having with Dr. Ahmad, that really applies to patients who have very superficial disease or non-muscle invasive disease. So that would include the TA, the TIS, and the T1, so invasion of the lamina propria. As soon as it gets into the muscle or beyond, like deeper, then it becomes a lot more serious, and the treatments thus become more serious. But this in general is how we're looking at bladder cancers. And when we're diagnosing bladder cancers, we're trying to determine what T stage does somebody have, because it's going to have ramifications for next treatments. So bladder cancer can be divided into non-muscle invasive and muscle invasive bladder cancer, and that's based on the depth of invasion. But the other important part is the histopathology. Most of the time, like 90% of the time, we're talking about urothelial carcinoma or transitional cell carcinoma. That's what bladder cancer means. There are other variant histologies that we don't talk about too often. They actually fall under the umbrella of variant histologies, but that could be things like squamous cell carcinoma or adenocarcinoma. So that the subtype of cancer also matters, and that is information we also get on biopsy reports. And then just for the lingo of talking about bladder cancer, we refer to bladder cancer very interchangeably with all these other terms. So you might even notice your doctor says these things and doesn't even realize they said two different things in the same sentence. Bladder cancer, urothelial cancer, urothelial CA, bladder CA, TCC, it's all referring to bladder cancer. It's essentially all the same. Okay, so if we took everybody with bladder cancer, those who had localized disease, I should add, not metastatic, about 75% of the time it would be non-metastatic bladder cancer, and non-muscle invasive bladder cancer. 25% of the time, right off the bat, upon initial presentation, people will present with muscle invasion. Of the people who get non-muscle invasive disease, most of them are going to be TA, some will be T1, and some will be carcinoma in situ. But what can also happen is that of the people who start off in the non-muscle invasive bladder cancer category, they can progress to develop this later on as well. So that's where all of those treatments like the BCG and all of the frequent cystoscopies are designed for, is to try to prevent people who have non-muscle invasive disease from prematurely converting over and progressing to muscle invasion. So I'm supposed to be talking a little bit about bladder cancer surgeries, and I wanted to give an overview of what the general treatments are and where does surgery fit in, because surgery has different roles in different settings. So in general, and this is really just simplifying it, someone could have non-muscle invasive disease, they could progress to muscle invasive disease, or somebody can have metastatic disease, so cancer that has already spread. In non-muscle invasive disease, TURBT or surgery like a bladder scraping is kind of the common surgery that we do. It's diagnostic and therapeutic because it establishes the diagnosis, but it gets rid of the tumor. And then the intravesical therapies would be used in this capacity here. If someone was to have muscle invasion, then the surgery that we would typically be talking about would be bladder removal, that's cystectomy. And then there's other things too, like chemotherapy and radiation. And then if somebody has metastatic disease, surgery has a limited role. So at that point, it's generally medications to be used. So to talk a little bit about surgery. When we're doing surgery, we're going into surgery with a few goals in mind. Of course, we want to sterilize or remove the tumor as much as we can. We want to prevent the initial tumor from growing bigger. We want to prevent it from growing deeper, and we want to prevent it from spreading. At the same time, we also want to preserve bladder function as much as possible. Like, we don't want to be intentionally resecting with no regard and all of a sudden somebody's incontinent after the surgery. Like, we're trying to maintain functional outcomes to minimize treatment morbidity. So one of the common surgeries that we do is called a transurethral resection of a bladder tumor. Everyone's heard of this and everyone has some familiarity with it. Has anyone not heard of this before? I figured, okay. Has anyone seen this before, this apparatus? Unfortunately, okay.
I've never seen it.
You've never seen it, okay. I figured I'd include a picture because it kind of just shows you what the actual instrument is that's used to do the surgery. It actually has three components. There's this component here in the beginning, which is connected to the outer part here, which is the outer sheath. Then we have a middle component. This is where we can operate the device with our thumb to move this electrified loop. And that's what allows us to scrape the tumor bit by bit to get it out. And then once we've scraped the tumor, we can actually like open everything up at this location. So it basically leaves this open sheath in and everything drains out. And then we have a lens at the end, and the lens is what allows us to see. It has a little bit of a 30-degree angle generally, so we can kind of look around corners to make sure we're not missing anything. But this is the whole apparatus. And then in the old days, they used to actually have their eye to the device, but now we have cameras that clip on and stuff. So a little bit better for us. But this is the resection or resectoscope that we use for TURBT. So TURBT, it's an endoscopic procedure. Most of the time, it's a day surgery. It can be performed under general or spinal anesthetic. It does involve the insertion of a rigid scope, and I showed you that resectoscope because I wanted to demonstrate that there's so many parts to it that it almost has to be a bigger size to be able to fit. So sometimes after a TURBT, it's very normal to have pain when you pee, it can burn, it can sting. That's because there was a big scope in the urethra, and it's purely related to that. And with this surgery, as I mentioned, bladder tumors are scraped away. We burn the base of the tumor, we make sure there's no bleeding, and then often there's a catheter inserted, sometimes for a short period of time, sometimes for a week or so. It kind of depends on the extent of the resection and just what the surgeon deems is safe for the patient. Side effects of surgery. So the side effects of a TURBT could be burning, catheter irritation. I've yet to meet a patient who was okay with the catheter. Most people don't like them. Infections. Infections are pretty uncommon, but they can happen, not just at the time of surgery, but weeks later, 2-4 weeks later. Incomplete tumor removal. Sometimes if the tumors are too big, we have limited abilities to resect it all, then it's safer to break it up into different sessions. Bleeding or clots, so blood in the urine. And that can happen not just after surgery, but it can even happen weeks later. It's very common actually that the urine will be clear for a few weeks, and then all of a sudden you're peeing blood or you pee some clots. Generally that's because a scab has come off or something, and that's why there's some bleeding. Most of the time it's self-resolved, but some of you may even be aware of like situations where there's so much bleeding that you had to go to the hospital, and that is the right thing to do. Bladder perforation, not very common, but can occur, and that happens when a small hole is made in the bladder. Thankfully, not overly common, as I was mentioning. But these pictures kind of demonstrate, admittedly in a very small tumor, what this would look like if you were in the operation seeing this. So the loop looks a lot bigger than it actually is because we're zoomed in. If there's a tumor right here, we kind of get beyond it, and then we have a foot pedal that controls the energy to scrape it bit by bit. And so then there's no more tumor, and then you end up with this scar here. We make sure that it's not bleeding, and then you're kind of done. But if we were to look back into the bladder 3 months, 6 months later, this would basically look like the tissue beside it. It would almost look completely normal. So it's like a temporary scab, if you will. So the TURBT not just manages the disease, especially in non-muscle invasive bladder cancer, but it's what establishes the diagnosis. And there are important pieces of information that we glean from the pathology report when these TURBTs are done. Specifically, what we're looking for is the grade of the tumor and the depth of invasion. More aggressive tumors are considered to be high grade, less aggressive tumors would be low grade. And then the depth of invasion coming to that T stage, for us in general, what we care about the most is it into the muscle or not? Because if it's into the muscle, we're not going to be wasting time with TURBTs. That just wouldn't be sufficient. And the reason is, when I showed those diagrams of the different layers of the bladder, the TURBT can basically go down to the muscle. It can't go through the muscle. So if you have cancer in the fat, the TURBT is not enough. We have to make a hole in the bladder in order to get it all. That's why if it's into the muscle, it's theoretically at risk of having disease beyond the muscle, and we know the TURBT won't touch that. So it really is only for non-muscle invasive disease. It's about 3 to 4 weeks here. Yeah, it used to be longer when I was a trainee. So it does take some time. Great question. I don't know if you heard in the back, the question was, how long does it take to get these reports? And it's about 3 to 4 weeks. So again, the TURBT is what helps us differentiate between does somebody have non-muscle invasive disease or muscle invasive disease. And there are important factors too when it comes to TURBTs, because as I've mentioned to some patients, even in the room, if you have non-muscle invasive disease, it can almost become a chronic problem. You're going for regular checkups, you might have tumors come back, you might have to have a TURBT because of recurrences, and recurrences can happen in up to 70% of patients. So it's important to have close follow-up. But what we're also trying to prevent is disease progression. We don't want it to invade deeper into the bladder if it does come back. We want to keep it very superficial or not come back at all. I'll probably skip over this a little bit. I think Dr. Maud spoke about it, probably spoke about the postoperative mitomycin C, which is like a chemotherapy wash after the bladder resection. I always use the analogy, it's kind of like mouthwash after you brush your teeth, like it's a little bit preventative, a little cherry on top if we can give it. But that's in the immediate postoperative period. But then all the other medications that Dr. Maud reviewed, those are generally like weeks and months after the original surgery. Yes, skip over all that. So here's the big one, radical cystectomy. Probably why a lot of people came here today is to learn a little bit more about this option. Has anyone not heard about radical cystectomy? Everyone knows what that means? Okay. So radical cystectomy is a very major operation. So I'll talk a little bit about the indications, the overview, what's involved, and what that kind of looks like. In terms of indications for cystectomy, the most common one would be muscle invasive disease. So if somebody had muscle invasive disease, a radical cystectomy is on the table as an option to manage it. A radical cystectomy looks a little bit different in a man than a woman in terms of what organs can be removed or should be removed, which I'll talk about, but muscle invasive disease is the most common indication. Now, if you had some variant histology, for example, like I could rattle off a number of them, plasmacytoid or whatnot, squamous cell, there are certain subtypes of bladder cancer that even if it's not into the muscle, there's data to suggest that an early cystectomy would be appropriate. If there's prostatic involvement, so in men, if the bladder tumor is actually invading from the bladder into the prostate, to us, that's another indication to consider cystectomy. If we can't fully resect it, sometimes, not necessarily based on volume of tumor, but there are some people whose bladders are difficult to reach certain spots. If we can't resect everything, then taking out the bladder is on the table as an option. And then another one is BCG refractory disease. So patients who have gone through all the different intravesical options that, again, Dr. Maud probably covered BCG or all the different various options. If they've done that and it keeps coming back, then at that point, it's not unreasonable to consider taking out the bladder. It is a little bit heavy-handed, kind of like hitting a nail with a sledgehammer, but sometimes it's necessary if you've exhausted all of your other options. So when it comes to radical cystectomy and what that surgery looks like, I kind of break it up into three parts. There's bladder removal and or other organs as necessary, lymph node removal, and then we have to create some sort of place for the urine to go, because if you don't have a bladder, it has to go somewhere. And we call that a urinary diversion. I don't know how well this transmits to you guys, but in terms of what's involved in surgery, so we remove the bladder, of course. In men, we also take the prostate. So we also call it a radical cystoprostatectomy because we're taking bladder and prostate. In women, classically, a lot of the female gynecological organs are also removed. So uterus, ovaries, fallopian tubes, cuff of the vagina. Sometimes we can spare those organs, but that is not necessarily just a yes or no, we can spare it. It's more dependent on where the tumor is. So if the bladder is like a 3D structure, if you have an invasive tumor in the bottom part of it, which is closest to the female organs, leaving them behind may not be the most ideal because there's a chance that there could be microscopic disease into them. Whereas if somebody had a tumor on the side of the bladder or top of the bladder, in those patients, we probably could spare the female organs. So case by case. Lymph node removal, in general, we try to take out more than less, but we do take out a lot of lymph nodes. And then urinary diversion. There's a lot of different types. Ileoconduit is kind of the most common. Neobladders are another. And then there are continent cutaneous reservoirs that can also be performed as well. In terms of preparation for a surgery, like I can't emphasize enough that this is a very major operation. Like generally speaking, we're talking like an 8-hour operation and probably the most morbid operation that we can do, quite honestly. And so that requires a lot of preparation. It requires preparation in the form of imaging immediately before surgery. A lot of people will go on to get chemotherapy before surgery, for example. Well, we're still going to do imaging before surgery because God forbid that something popped up like metastatic disease weeks before surgery, then we should definitely not put that patient through such a major operation that will be life-changing if it's not going to improve their longevity. Blood work, of course, we have to do extended blood work. We send patients to see intrastomal therapy preoperatively. So these are going to be the nurses who are tasked with managing the stoma bags, and they often will mark people ahead of time. And what that process generally looks like is they meet with you pre-surgery, and you kind of wear the clothes that you normally wear, and they're going to get you to sit and stand, and they kind of see where the creases in your abdomen are to mark the ideal location. So all patients will be seen by intrastomal therapy. Anesthesia, this is a major operation, so you have to be cleared from a cardiac or respiratory standpoint for such a major operation. And then generally, people will fast before surgery, clear fluids the day before, and often do a bowel prep as well. So in a male, this is just to give you the perspective of how it looks like. When a male is having a surgery, they're lying down on their back, and what we're taking out, this is the patient anatomy. If they were sliced down the middle here, the bladder's here, prostate's here, and the urethra's here. So we're basically taking out all of this. But the reason I included this is just to show you some of the nearby structures. So right underneath the bladder and the prostate is the rectum. So when we're taking out these organs, like the bladder and prostate, we're doing it in a very careful way to not injure something like the rectum. Like that could be a very, very bad thing to happen, which thankfully is very rare. But it just goes to show how close all of these organs are within the pelvis. In a female, another name for the radical cystectomy in a female is an anterior pelvic exenteration. And that's because we're taking out all of these various organs in what we call the anterior or front part of their pelvis. So we're leaving behind the rectum, but everything in front of it would go as well. Extended pelvic lymph node dissection. So this is just showing a very good lymph node dissection. And the orientation in this view would be if somebody was lying on their back and you're kind of looking into their pelvis, this is the right side of their abdomen. So things that we can see here are the aorta and the common iliac artery here, and the external and internal. But the point that I'm trying to show here is that normally if somebody didn't have a surgery, if we just opened up the pelvis, you wouldn't see these structures actually. What we would see is a whole bunch of fat all lining this whole sidewall, lining here. You wouldn't even see these vessels. So when we're doing a lymph node dissection, what we're doing is we're actually taking away this fibrofatty tissue. You can't necessarily see what a lymph node is or isn't, but we take all of this fatty tissue until we're left with just the bare minimum, like the skeletonized vessels and nerves, and we take all of it away to analyze it for possibility of cancer deposits. And then this is a quick schematic showing what an ileal conduit would be. So now we're talking a little bit about urinary diversion. So bladder's out, prostate's out, lymph nodes are out, but now we need to put the urine somewhere. If we're taking out the bladder and the prostate, we still have kidneys that are making urine that drains down a ureter. So we need to put it somewhere. So this schematic will just show kind of what it looks like when we're making an ileal conduit. So we actually take the small intestine, the terminal ileum, we isolate a section of ileum that we need for the urinary purposes, but we'll of course need to reattach the bowel for its main purpose, which is for the bowel contents to flow. And we take that section of isolated bowel and we bring it to the skin for one end to be a stoma, and then we sew the ureters into the conduit. So there's a lot of moving parts here, and I describe it like this because I mentioned earlier that a radical cystectomy can be one of the most morbid surgeries that we do, and part of that is not necessarily because it's so risky or anything like that, it's that there's a lot of moving parts. Taking out a bladder and prostate, the taking out is the easy part. It's your body adjusting to this new physiology that's the hard part. And when we're doing all of these sorts of surgeries and tying of things together, we have in here inherently, there's a bowel anastomosis, so bowel touches bowel, or connects to bowel. We have the one ureter connecting to the conduit, another ureter to the conduit. We have to close the other end of the conduit so that urine doesn't leak out, and we have to bring the other end to the skin. Anytime there's a connection point, that's a point where something could leak. It's also a point where something can narrow down over time and block, or like a bowel obstruction, for example. This is just another diagram. So I wish it was that simple where we could just take a section of bowel and move it over here. But the bowel has its own blood supply. Like we can't just cut that part out because it has to still get blood supply like normal to survive. So this is really what it looks like. So we actually have to isolate a section of bowel with the fat, or also called the mesentery, that has the blood supply. And then we save that blood supply and we do it in a way that protects it. And we isolate that for our purposes, and then we reconnect the bowel back together as well as the mesentery. And we close the mesentery because we don't want things to herniate in and out internally. We call that an internal hernia. So we prevent that from happening as well. And so again, just another schematic of what that would look like. And then this is generally what it looks like. If somebody has an ileal conduit, generally they're going to have a little pouch on the right side of their abdomen with a little bit of pink mucosa sticking out from the stoma itself, which is a part of the ileum. Now there are other urinary diversions. So another one that can be performed is called an ileo-neobladder. Neo meaning new, bladder meaning bladder. And one question I always get is, can't we just come up with some sort of like external device that can like serve as the bladder? Can we not transplant the bladder in? Unfortunately, we don't have anything like that. So the only thing that we can do is we can use what you already have for a different purpose. And in the previous example, I talked about the ileal conduit. That's where we use about 15 to 20 centimeters of intestine for the purpose of the conduit. With the neobladder, we actually end up using more like 55 to 60 centimeters of intestine because we have to flip and fold it in a way that's going to serve as an internal reservoir, and then we anastomose it or sew it to the urethra. And then all the other things still apply because we have to plug in the ureters to the bowel at some point to get the urine into there. And while this seems like it would be a great option, because there's more sewing, there's the potential for more problems. But also, it's not going to function like a regular bladder. Like you're not going to have sensation like your normal bladder does. Often people have to. Hello, that died. That's okay. So often people have to catheterize themselves because it's not going to fill and empty like a regular bladder. So you have to, sit down on the toilet, flex your abdomen, bear down, and then catheterize afterwards to make sure you're actually emptying because you're learning like a new way to pee. You're gonna switch it. Thank you very much. But this is a neobladder, and so it's not for everybody. And then what I mean by that is it's not as simple as saying it's your choice because sometimes there are medical and surgical considerations as well that we have to factor in. So you have to have good kidney function. Your tumor can't be too close to the urethra because that's going to be an area that stays inside. You have to be in good shape. Like you have to have the dexterity to catheterize, to take care of yourself because it's a lot more work. And you have to be willing. It is something that you have to sort of be actively participating in your own care. But for the right person, it can be a good option. Yeah, it can be a very good option. And then the other one that we don't do very often would be a continent catheterizable reservoir. So for example, like an Indiana pouch or something. This is still an internal reservoir, but it also combines a stoma with that. So you have a stoma to the skin, but you catheterize the stoma instead of wearing a bag all the time. I know in BC they do this a little bit more, but they're kind of the only place. And I would say this might be a better option for somebody who, I mean, it's a little bit personal preference too, but it's classically more for somebody who may not have as much dexterity, or maybe maybe they're like wheelchair bound and they can't get to the bathroom, so they need something where they could be sitting and just catheterizing that way. So that's another option. And this, can you see that? Hopefully you can see that. This is showing you a little bit of the what goes into the decision making from the physician side and the patient side when we're trying to figure out what urinary diversion would be best suited for a particular patient. Like, what's their chance of recurrence? Do they need have they had previous radiation? Is it a young female or an older female? Like, do they need their reproductive organs or not? How comorbid is the patient? Like, is it somebody who's just run a marathon last Saturday, or is it somebody coming in on oxygen that they take at home or in a wheelchair? Like, these are all factors that have to be considered, because not only are we figuring out urinary diversion type, but we also have to figure out, is surgery the right option? Is bladder removal too big of a surgery for some people? And with that, it's a good transition to this slide, because this is something one of my teachers once taught me, is that good surgeons know how to operate, the better surgeons know when to operate, but the best surgeons know when not to operate. So sometimes if you're having the discussion about muscle invasive bladder cancer and your doctor says to you, you're really not a good candidate for cystectomy and bladder removal, there's a reason why. And sometimes just acknowledging that is important as well. And then just lastly, just a comment, as much as I'm talking about surgery and bladder cancer and cystectomy is not the only answer. For anyone who are here who may or in the future might develop muscle invasive disease, don't feel that your life is destined for bladder removal. Some people can save their bladders and can get radiation and chemotherapy and do very well as well. But again, it does involve that discussion with your physician, with other care providers. Often we utilize like a multidisciplinary approach. You might meet with the surgeon, then you meet with the radiation doctor, and you meet with the chemotherapy doctor. And that's very important, because you want to use this as an opportunity to gather information and make a decision that fits best for you. Some people are very confident that they want bladder removal, and some people will absolutely refuse it, even if it means that you can't get all the cancer. So it has to be an individual decision. And I think that's pretty much it. Just some concluding comments there. But I think at the bottom is the most important, that if you want to have the best outcomes for bladder cancer are among those who are diligent with their follow-up, that they have their regular cystoscopy, that they have their regular imaging, and they're overall compliant, and they stop smoking. All of those things are very important for a good bladder cancer outcome. I think that is it. Yeah. Thank you.
For any questions for Dr. Nayak?
You said that the TA T1, there's like a 20% chance that those will progress to T2. What's usually like the length of time for that progression? Like, you catch with someone with cancer, like a month, 2 months?
It could be any time, but I would say it's not usually in the months. Like, we're talking like in the years to come, more commonly. Yeah. But it's sometimes hard to answer that question, because somebody who has had a scraping and they recur with a large recurrence like 6 months later, it's going to probably not do as well as somebody who had a surgery and they went 3 years without a recurrence, and it was a small one when they did recur. So it depends on the person too. I have seen, sorry, I make a comment that, like, I get referrals from other urologists as well, and in the beginning I was a little bit maybe cocky, thinking, well, this person did a TURBT and I don't know the quality of their TURBT, so I have to do it myself, because then I know I've cleaned it out properly. And I've been very humbled, because I've cleaned it out properly, and 3 months later they had recurrent tumors. And it just goes to show, sometimes there's very aggressive phenotypes of bladder cancer. It doesn't matter what we do, it's just destined to come back.
What's the percentage of bladder cancer patients that end up needing radical treatment?
Like cystectomy or
Yeah.
radiation?
Yeah.
I would say it's probably under 30%. But I'm estimating. I don't know if you would say anything different, Dr. Ahmad.
That's what the number is for, like, of all comers initially.
Yeah.
About 30 of them have involvement in muscle. Candidate for treatment, not for treatment.
But there will be additional people who are in that 70 who eventually need to have the bladders out too, or radiation. Yeah, question?
Someone who's already had
Come on
an
up,
RC.
Angela. Thanks.
Someone who's already had an RC.
Great question. So assuming that the kidney function is normal, we do also consider the final stage of cancer, because once the bladder is removed, it all gets analyzed just like a TURBT specimen, but more detailed because we have the whole organ there. So if somebody had kind of T1 or less disease, we'd probably at least do it every 6 months for the first 2 years, and then space it out thereafter, maybe even space it out at the 1 year anniversary to annual. But if somebody had T2 or T3 disease on their radical cystectomy specimen, I'd likely do imaging a little bit more frequently, even every 3 months for the first year, and then every 6 months for a few years. It's a good question, but it also depends on a few things. In the beginning, I would say CT, and assuming kidney function is normal and the patient could tolerate contrast, a CT chest and CT IVP or abdomen pelvis would be what I would normally do. But CTs have a lot of radiation with them, and if you have a cancer diagnosis, you've probably had many CTs. So sometimes we might incorporate ultrasounds that have no radiation or MRIs. Depends on what we're looking for.
I'm always getting MRIs. So I'm like curious because I talked to other people, I'm like, oh, we're having CT scans, you're having, but I'm young. So,
I'm sure that is the reason, yeah.
okay.
Yeah. Not that we want to radiate people older than you, it's just, I'll clarify that. The reason between CT and MRI, and this is just on the honest truth, is CTs are a lot easier to read. Because it's kind of like a quick phase, like urologists can look at it and interpret it ourselves. We don't even need a radiologist most of the time. But MRIs have so many different phases that you can't just look at one set of pictures and come up with what's the situation. You have to combine different phases. So it's also a little bit trickier to read the scans.
Great, thank you so much.
Yeah, you're welcome.
Appreciate that.